Specialty Hospital, Sanat Nagar, Hyderabad. Firstly, I wholeheartedly congratulate and my wholehearted greetings to each and everyone, my colleagues and all laboratory fraternity for celebrating 8th National Medical Laboratory Professional Week. So, the part of National Medical Laboratory Professional Week, we are conducting online webinars every year from last year. This year also we are continuing the same. Actually, today this talk was actually should be presented by one of my colleagues, Mr. Guneshwar, but unexpectedly, due to health issues, within a very short time, I used to present this. The topic was factor 13 assay. Let's start the session. Yeah, factor 13 assay. Generally, in patients who are having mild to severe bleeding tendencies, bleeding after surgeries, delayed wound healings, umbilical cord bleedings, intracranial hemorrhage, soft tissue hematomas, spontaneous abortions, miscarriage, recurrent miscarriages, and hematuria, gingival bleeding, joint bleeding, etc. In those cases, generally clinicians suspect factor 13 deficiency. This bleeding may occur generally in skin and mucosa, gastrointestinal tract, CNS system, genitourinary tracts, soft tissues, and joints also. Generally, factor 13 levels above 3 to 5%. If present means generally bleeding will be spontaneously stopped. Factor 13's half-life in plasma will be 9 to 12 days generally. Pure bleedings generally occur in less than 1% of factor 13 circulating levels. Patho Physiology. Factor 13 is a transglutaminase that circulates as a zymogen comprised of 2 catalytic A subunits and 2 carrier B subunits. These A subunits will be synthesized in platelets, monocytes, and macrophages. B subunits synthesized in liver. Both these units enter into plasma and assembles together to form factor 13 heterotetramer. This factor 13 is activated by generally thrombin. It is responsible for final step in the our coagulation cascade in the presence of calcium chloride. Generally, when we observe in our two pathways, intrinsic and extrinsic pathways, in the final step, in the present when fibrin forms fibrin clot, in the final step, this factor 13 role will be very crucial. Etiology. These factor 13 deficiencies are mostly inherited as an autosomal recessive trait. Generally, this inheritation due to gene mutations, mostly mutations will occur in A subunit gene and chromosome number 6. 70 mutations till now are observed, which are due to A subunit mutations that were due to missense and nonsense mutations. Till now, only 5 mutations are observed on B subunit mutations. That B subunit mutation will generally occur in chromosome number 1. What are the general causes of factor 13 deficiencies? Factor 13 deficiencies will generally occur mostly as we discussed due to gene mutations that will occur as a congenital disorder or passed through inheritance. Some acquired deficiency cases will be observed generally in liver failure cases, leukemias, inflammatory bowel diseases, disseminated intravascular coagulations. Screening. Generally, this factor 13 deficiency will be suspected in patients who are having normal PTFTT values, thrombin time is normal, and fibrinogen levels are also normal. We can do some screening tests like clot soluble tests also will be done before going to factor 13 deficiency assays. Reagents required. Generally, in our laboratory, the reagents we are using The kit will have an activator diluent, and detection reagent. Activator reagent will contain bovine thrombin, clot inhibitor, calcium chloride at pH 8.3. It should be reconstituted with 5 ml of activator diluent. The activator diluent will consist of NADH. We should reconstitute with 5 ml of distilled water. Detection reagent contains GLDH, synthetic peptide as factor 13 substrate, ADP, glycine ethyl ester, and alpha ketoglutarate. Should be dissolved in 5 ml before performing the test. Its stability of the reagents. At 37 degrees, the activator will be stable for 8 hours. Detection reagent is stable for 8 hours, and reagent mixture, which was prepared, will be stable for 4 hours only. 15 to 25 degrees. At 15 to 25 degrees, the activator stability will be 2 days. Detection reagent stability will be 2 days. Reagent mixture stability will be 8 hours only. At 2 to 8 degrees routine refrigerator, activator stability will be 1 week. Detection reagent stability will be 1 week. Reagent mixture stability will be 2 days. At minus 20 degrees, the stability of the activator is 6 months. Detection reagent stability will be 6 months. Reagent mixture stability will be 2 months. Sample preparation. We should carefully mix 1 part of sodium citrate solution with 9 parts of venous blood, avoiding any formation of foam. Immediately, we should centrifuge the sample at 1500 rpm for not less than 15 minutes at room temperature. The separated plasma will be stable for 8 hours at 15 to 25 degrees, 24 hours at 2 to 8 degrees, and we can preserve the sample for 2 months, up to 2 months at minus 20 degrees, so that we can perform the test on pooled basis whenever number of samples can get. Procedure for manual testing. We should mix equal parts of activator reagent and detection reagent. The necessary volume should be based on the number of tests we are performing, based on 1 test, 2 tests, or 5 tests. Based on that, we have to take these volumes. Mix 100 microliters sample with 100,000 microliters of reagent mixture. Start measuring the OD at 340 nanometers at room temperature. We should calculate the speed, calculate and take the reading of the speed of the change in absorbance after reaching the linear phase. Generally, this linear phase will be obtained after 5 minutes of the mixture of the both reagents and sample. This is the principle. Actually, the factor 13 in the presence of thrombin and calcium chloride will be converted to factor 13A. In the presence of reagents, glycine ethyl ester and peptide substrate, factor 13A will be converted to conjugate peptide glycerin ethyl ester, and ammonia will be released. This ammonia only we will again reacts with alpha ketoglutarate with NADPH and converts to NADP plus glutamate plus H2O. This reading, this color changing photometric reading, we should capture at 340 degrees nanometer, and we should calculate the value. Actually, we should prepare a standard curve in each laboratory using the normal plasmas. After catching this test value, we should compare the test value in the standard curve, and results should be given. Generally, this normal range of the sample will be 70 to 140% of the normal plasma. In our laboratory, generally we are doing all this factor 13, factor 5, factor 8, protein CS, and all these reagents in Sysmax CS 2400 coagulation angle, which is fully automated. We are not preferring manual tests because there is a chances of man-to-man manual errors or reading errors. For in manual methods also, whenever that reading device changes, we should prepare fresh curve every time, so that to avoid this manual errors, we are doing fully automated analyzer Sysmax TS 2400. This is the analyzer we are having in our laboratory. These factor assays were started 1 year earlier, 1 year before in our laboratory. Limitations. As we discussed in the principle, this test is final test result will be obtained and based on ammonia levels. So if any patient having high ammonia levels are in the plasma sample, it may give false results. And fibrinogen also interfere in the result. Very low level of fibrinogen and very high level of fibrinogen also interferes, which can give chances of false positive results. If fibrinogen is more than 6 grams per liter, you should dilute the sample in 1:2 ratio or 1:3 ratio based on the value of fibrinogen with isotonic normal saline. Treatment, many of us know, because most of us are working in blood bank only. We are we are issuing factors, cryoprecipitate, which are used to treat these patients. We are suffering with factor deficiencies. The factor 13 deficiency patients also treated with cryoprecipitates by injecting cryoprecipitates. Thank you, Ananda. Any doubts? Anything? Can ask.
Thank you so much, Balakrishna. That was very insightful talk. Like, any questions from the audience? Hope it is clear.
Madam, which patients will do, madam, factor 13?
Yes.
Hello. Yeah, 1 second.
For which patients will do the factor 13?
Yeah, as we discussed, patients who are suffering with severe bleeding disorders, even though having normal PT, FTT, and thrombin time values also having severe bleeding disorders, then we can suspect some deficiency of factor 13.
Okay.
So just in those cases, we can go for evaluation of factor 13 assay.
Okay. Thank you.
Yeah, I think we had one slide. See, bad obstetric history, that is infertility cases where the a patient who is not able to conceive continuously, she is aborting, and patients with systemic lupus erythematosus and HSP patients and leukemia, so they have an activating clot factor already. Okay, this must be suspected in a cases where actually where normal surgical profile is absolutely normal. The patient was taken onto the table and the surgery has been done. But despite that, the patient will die of a bleeding. So this we commonly encounter in obstetric practice. So after the surgery section or the hysterectomy or some instrumentation and all, the patient will mysteriously die of bleeding. So in such cases, because our testing is limited only to PT and APTT, we are not testing beyond that. There are many research articles which is quoting for this. The literature is available in the department. So which suggests that factor 13 deficiency is the one which is contributing to that. If we can detect that at an early age, we can save the patient. And as Balu has shared in one of the one of his slide in PPT. So after fibrin, where the factor 13 is been activated. Can you show it again, Balakrishna? Yes, this picture. So if any of a patient is coming to us, say, suppose if we are suspecting a DIC in that patient, so it will come for FDP and all those, not beyond that. But if you can see this picture clearly, it is showing that where exactly is the factor 13 is coming into play. Okay, our testing parameters in the routine lab is restricted only till fibrin and FDP. Okay, we are not testing on this particular parameter. If these can be introduced in our routine antenatal screening or in the surgical profile, will be benefiting the patient who are suffering with these particular deficiency because of congenital reasons or because of the acquired causes. Hope I am clear.
Yes, madam.
Yeah.
In some cases also where internal bleeding is there, coagulation mechanism will be every time in active process only. In those cases, factor 13 will be utilized in body. In those cases, we will go for PT and TPT, and when normal, patient will be taken for surgery. In those cases, patient will may have chances for dying due to lack of factor 13 assay. Bleeding will not control.
So if detected early, this can be treated with the FFP and the cryoprecipitate. Okay. So maybe in the future, like how we have the factors, other factors available, maybe we can make the factor 13 concentrate also and give the patient who are the needy ones. So if there are no more doubts, I think we can conclude for today, or any other questions by the audience. Okay. There are no more questions. Thank you one and all for joining this session, and it's a good start from the laboratory professional week. Please continue to do such motivational and upgraded techniques to help your colleagues. Yeah, thank you one and all for joining this.
Thank you, madam. Thank you for your valuable time and guidance, madam.
Thank you.
Thank you. Thank you very much, ma'am.
Yeah,
You are
thank you.
always encouraging our lab professional.
Thank you. You're also equally participating. Best of luck, Bharat, for tomorrow.
Yes, ma'am. Thank you. Now I am